everyone. My name is Clémence Dallaire. I am professor at Laval University, and I'm also chair of CASN Research and Scholarship Committee. It is with great pleasure that I welcome all of you to the October session of the 2019-2020 Lunch and Learn series. I'm sure many of us are familiar with the concept of the lunch and learn, where faculty members come together during their lunch hour to share with one another projects they are working on and to dialogue and discuss methodology, successes, and challenges they encounter in their work. We wish that the webinar series serve as inspiration and a networking opportunity for participants while recreating the collegial feel of the Lunch and Learn series. This year, each session will highlight one of CASN national research priorities for nursing as a theme. Today, for this second session of the 2019-2020 series, the theme is Nursing Research Priority number 2, which is chronic disease management and care delivery across space and time, and we will hear from Dr. Rick Sawatsky. Dr. Sawatsky research focuses on the validation and use of person-centered outcome measures and quality of life assessment tools in healthcare, with a particular emphasis on people who have chronic life-limiting illnesses and their family caregivers. He is the method cluster lead for patient-centered measurement with the BC Support Unit, a multi-partner organization that carries out patient-oriented research in order to improve healthcare outcomes for all people. Rick's current research includes projects on statistical methods for individualized person-centered outcome measurement, the integration of electronic quality of life assessment in clinical practice, the use of person-centered outcome measure for healthcare decision-making, and finally, integration of a palliative approach. Today's webinar is titled Use of Quality of Life Assessment Tools with Older Adults Who Are Living with Chronic Illnesses and Their Family Caregivers. Dr. Sawatsky will share how the use of QOL assessment tools are enhancing person-centered care practices with older adults who are living with life-limiting illness and their family caregiver. After Dr. Sawatsky's presentation, we will have time for questions. To submit a question, please use the question and answer function on your screen. Once you have finished typing your question, please don't forget to hit the send. So I will now turn the session over to Dr. Sawatsky so we can begin. Dr. Sawatsky?
Thank you. Thank you very much for the introduction. Can everybody hear me okay? I assume so. So I'll proceed. I'm very grateful for this opportunity to share about the research we have been doing on quality of life assessments, focusing specifically on older adults who are living with chronic conditions, as well as on their family caregivers. And so as was just introduced, the objectives for today, I'm going to say a little bit, provide some background information about quality of life assessment, what this entails, and how we can use quality of life assessment tools in clinical practice for this population. I'm then going to say a few things about a quality of life assessment and practice support system. It's an online type of system. There's many quality of life support systems out there that can be used to support the use of quality of life information to support person-centered care planning and decision making. And in our case, specifically, again, focusing on older adults and their family caregivers. And then the third thing I'm going to talk about is the research we've been doing on the use of these types of systems and the use of quality of life assessment information in clinical practice. And I very much hope we'll have some time for discussion. So that's our goal. I am going to start with a very short 2-minute video. I should be forwarding my slides here. There we go. So that was the outline and objectives. I'm going to start with a very short 2-minute video introducing the notion of quality of life assessments. This is a video that's still in progress of developing, so you got the honor of seeing an initial version of it, and as part of the knowledge translation work that we have been doing. Here you go. Sit.
Talking about your health can often feel overwhelming, as it can be easy to forget or not even recognize key information to share with your healthcare providers. Sometimes the aspects of your healthcare provider your life that you may believe are unrelated to your health are actually important to share with your healthcare provider. This kind of untapped information could limit your healthcare team's ability to tailor your care to best meet your needs. Your healthcare providers are not always able to tell what the daily challenges of your life are, unless you choose to share them. And you might not recall every relevant detail on the spot. It is more than just about your symptoms and physical health, but also your emotional, mental, or social well-being and your experiences with care. Fortunately, there is a way to address these concerns. Quality of life assessments offer a way to improve the care provided to you. They include questions that prompt you to share key information about your care and quality of life that may otherwise be forgotten. Your responses can help build your relationships with your healthcare providers in order to create a better treatment plan that is tailored to you. And because the questions ask you about how you feel and how you perceive your own health, there are no wrong answers. Your responses are there to monitor how you are doing in a way that goes beyond simply asking, "How are you doing?" The exchange of thoughts and concerns regarding your quality of life allows your healthcare provider to become someone who better understands and encourages your personal perspective on your own health. And including these quality of life assessments into your care plan may spark conversations that are essential in achieving a more trusting and therapeutic relationship.
That was a very brief introduction to the video that we've been developing, introducing the idea of quality of life assessments. I'm just going to open up the slides again here. And I'm sorry about the hiccups there in the presentation mode. So basically, in a nutshell, now that you've had a basic introduction to the idea of quality of life assessments, I'll continue with providing a little bit more background on what this entails and how we can use quality of life assessments in clinical practice. In a nutshell, quality of life assessments involve 3 basic questions that are, of course, foundational to all the care that we provide. The first question being, how are you doing? The second question being, how is your care? And the third question being, what matters to you? Increasingly, there is use of tools to facilitate this type of decision-making process and the use of answering these types of questions. So our focus today is on the use of standardized tools to support addressing these foundational quality of life assessment questions with the ultimate goal of enhancing person-centered care. And here a key characteristic of person-centered care is to enable patients and families to tell their stories in sharing about their distress and well-being and sharing this information with all people who influence their care. Standardized tools can help facilitate this process by asking patients to respond to a fixed set of questions about their health outcomes and their experiences with care. These tools are referred to as patient-reported outcome measures, or PROMs, and patient-reported experience measures, or PREMs. PROMs ask patients to rate aspects of their physical, emotional, psychological, social, and sometimes even existential aspects of their health and quality of life. whereas PROMs ask patients to rate aspects of their care, such as whether they've been treated with dignity or respect, and whether they were involved in decision-making in the way they wanted to be involved in decision-making about their own goals of care. There are also PROMs and PROMs for patients as well as for family caregivers. Together, the responses to these questions can be used to inform further assessment and to support person-centered care planning that focuses on the needs and priorities of patients and family caregivers. The next slide here shows an example of a quality of life assessment tool that's widely used in palliative care. As you can see, it consists of 14 questions that ask people to rate aspects of their physical, psychological, existential, and relational well-being or quality of life. So there's questions about symptoms, questions about feeling physically well or physically unable to do things, and those comprise the physical aspects of quality of life. And then there's questions about depression, being nervous or worried, sad, or fear of the future, and they have to do with psychological aspects of their quality of life. Just showing this as an example. There are similar tools available for family caregivers. Here's a quality of life and life-threatening illness family carer version, version 2 of a quality of life assessment tool. And you can see here, this one actually consists of 21 questions, and it has these different domains here. I didn't list all the questions, just providing this as an example. In addition to those patient-reported outcome measures, as I mentioned, there's also patient-reported experience measures. Here's an example of the Canadian Health Care Evaluation Project, or CAN HELP instrument. There's an instrument here that can be used for people with chronic life-limiting illness, so more towards the end of life, but not just at the end of life, can also be used earlier on. This tool consists of 21 questions as a patient version. There's also a family caregiver version, and there's also a post-bereavement version for family caregivers after the patient has passed away. So here's an example. Your emotional problems, for example, depression, anxiety, were adequately assessed and controlled for. People can rate that, and we then can use that information to engage further discussion if it's identified as an issue, and to then follow up with further assessments and care planning to address the issue. There's been a lot of research done over the past 40 years. Actually, the first study on quality of life assessment was done in the 1970s, was a randomized controlled trial. And there have been many, many, many randomized controlled trials and qualitative research and systematic reviews that have been done since to examine the use of these types of tools in clinical practice and at other levels of decision making. And in a nutshell, these tools, the results of these studies suggest that these tools can help to empower patients and family caregivers to guide more meaningful conversations directing at the needs and priorities that matter to patients and family caregivers, to improve their participation in decision-making, goals of care planning, and so on, and ultimately to promote person and family-centered care. What I just described was the use of this kind of information at the individual level of care. But it can also be used at the population level of care, as is shown in this slide here, where this information can be used, can be aggregated and used to support quality improvement initiatives, to support decision-making about policies, and possibly allocation of resources, drawing attention to things that may otherwise not have gone noticed, and doing so at the population level. Despite all this research that's been done over 40 years, it's more than 4 decades on quality of life assessments, and relatively compelling evidence, depending of course on context and applications on the use of these tools, their routine use in clinical practice and at population level decision making is still actually quite limited. And so we have embarked on a research initiative over the past 7 years to investigate this challenge, which we frame as a knowledge translation problem. And we focus on investigating how we could design a system or an approach that could support the use of quality of life assessment information by all knowledge users, including patients and family caregivers, healthcare providers, decision makers, and to focus our focus has been on the care of older adults who are living with life-limiting conditions and their family caregivers. But of course, these tools can be used in many different populations as well. So in 2012, we established what we're calling a QPSS innovation community. QPSS stands for Quality of Life and Practice Support System. It includes a patient and family caregiver engagement panel. It includes a clinician and decision maker panel with leaders. It includes a researcher panel with researchers from throughout Canada, the UK, and Sweden, and it includes a health technology panel. And we've been focusing on efforts on designing systems that can support the use of quality of life information by all knowledge users, and also testing the efficacy and use of the systems. So I mentioned we refer to this as a quality of life and practice support system. This slide is showing a bit weird for some reason. These are online systems. There's many available that can be used in clinical practice to support the use of quality of life assessment instruments, to provide feedback to users about what the scores are and how the scores have changed over time, to support decision making both at point of care but also at population level decision making, and to integrate that information with other health information systems. Briefly, the QPSS is an online person-centered health information system that was collaboratively designed to support exchange and use of information focused on quality of life of patients and family caregivers. It is patient-driven rather than provider-driven, so the data are owned, managed, and shared by patients and family caregivers, which is quite different from conventional health portals or electronic medical records, which are controlled by the provider with a portal for the patient to perhaps view their information, but they don't actually control it. So this is patient-driven and includes tools that measure and track outcomes and experiences that matter to patients and family caregivers, including their symptoms, quality of life concerns, healthcare experiences. And it also includes practice support tools that help to, that include, first of all, reports with instantaneous feedback on results and analytics for shared decision making, and also integration with other health information systems. Our innovation involves integrating QPSS into practice, which includes community-based primary care practices, primary care homes, but also in hospital settings and other types of teams. Patients and family caregivers are at the center. They have the opportunity to complete quality of life assessment information. It gets entered into a health record that is managed by the patient and family caregiver, and that can be shared and integrated with a patient electronic medical record that is accessed by healthcare providers to then support practice and decision making towards achieved improved outcomes. Our focus is on person-centered care planning, including shared decision-making, goals of care, improved pain and symptom management, and support focused on quality of life. We've been using, we're using the term QPSS to refer to any type of system that might be available. So we're not trying to promote any particular system here, but this is the system that we have been using with our technology partner, Cambian. It includes two arms. One is the Navigator system, which is managed by patients, where patients can enter their information. They could also connect to their biomedical sensors, whether they use Fitbit or blood pressure monitoring or whichever. They could also use it to share information and with their providers. And the providers can view this information. The providers in turn can also send assessment questions to the patients. They could share educational material, treatment plans, and so on. This is the Cambian Navigator system. I'll click through it very quickly. It includes a series of assessment tools that patients can select and complete, and has some other functionality as well. Here is an example of a type of question of the instrument that I just showed, the McGill Quality of Life Assessment Questionnaire. The other arm, as I mentioned, is a coordinator system, which is what is accessed by the healthcare providers. And I thought that often with these types of presentations, these systems are a little bit of a black box. People talk about them all the time, but we don't necessarily have a good sense of what they mean. So I thought I'd share with you a brief 3.5-minute video that shows that we use to kind of orient clinicians to the use of this system in clinical practice. So I'll show that right now. Oh, you need to click on the play button. So this is an informal
This demo
video.
will show you how to review the quality of life assessments completed by clients and family caregivers. Upon receiving notification that quality of life assessments were completed by your clients or their family caregivers, the next step is to log into the Cambian Coordinator application. A window will pop up with the list of the participants in the intervention group. You will see the participant name, the study ID code assigned to the participant, the date in which the participant enrolled, and the date of their last assessment. Click on the row of the participant you wish to review. Another window will pop up. You will find demographic data specific to your participant in the upper portion of the window, while the list of quality of life assessment tools are found in the lower portion of this window. You will see 5 columns pertaining to the quality of life assessments: the name of the specific QOL assessment tool, the date it was sent to the participant, the target date for completion, the completion date, and finally the status of the quality of life assessment tool, either completed, in progress, or pending. In this example, the ESAS-R was assigned once and is pending, while the MQOL-E was completed 3 times with the 4th in progress. To the right of the columns, you will find the graph icon. Simply click on this icon to produce a QOL assessment profile based on the participant's most recent questionnaire responses. This pictorial representation will allow you to easily identify and focus on areas that are of concern to your client or family caregiver. Looking at this specific example, the domains of concern are physical, feeling like a burden, and quality of health care. The first bar on the left refers to the MQOL-E total score. By moving your cursor to the top left of the toolbar, click the word SCORE to generate a trend line that corresponds to this client's total MQOL-E scores across time. You can click on any of the domain names in the toolbar to generate a trend line for any of the specific domains. Use the scroll bar to the right of the window to review specific symptoms that relate to these scores over time. After accessing and reviewing your client's quality of life assessment, you might be interested in reviewing the respective caregiver's quality of life responses. Click on the caregiver to open the family caregiver's account. Click the graph icon to view the family caregiver's quality of life assessment profile. As with the client's quality of life profile, the caregiver's graph will readily depict areas of concern. In this example, it is patient condition. Once you are done with reviewing the profile, close the window. If you require any assistance or have any questions, please contact the research team at 1-877-898-4630.
Great. So hopefully that gives you a little bit of sense of what we're doing. I thought it might give a bit more of an applied kind of behind the scenes kind of overview. This is, by the way, an edited introduction. Our information is much more expansive, of course, but I didn't want to make it too long. But you get the idea, I think. So we've been doing research over the past while, a series of studies focusing on the use of these types of systems in clinical practice. Again, I'll reiterate, it's not just about one particular system. We've used two different ones, and we're currently using the one I just showed you. But it's really more about the idea than about the particular system. Our studies are all designed kind of along the lines of an implementation science and integrated knowledge translation type of framework, where we first work with local teams to adapt to their local practice environment, where we establish protocols with the team to figure out how do you actually integrate it into your practice environment. We agree upon particular tools that might be useful in that context. We have a database of over 200 quality of life assessment tools that people could select from, and then establish an agreed upon protocol in collaboration with both patients, family caregivers, and the clinical team. And then we go in our evaluation stage, where we do trials to figure out, is this really having the impact that we're hoping that it will have? And so we're currently in the final stage of a randomized control trial in home care practices for older adults and family caregivers. And we have several other trials that have been going on as well. One focused specifically only on family caregivers at end of life, and another one led by Kara Schick-McCarroff at the University of Alberta that focuses on people with kidney disease and receiving dialysis. And then the third stage is about sustainability. Now that once we have the evidence, what needs to be in place to actually make this sustainable? And that's where we really work with the decision makers and leaders and healthcare providers and patients and family caregivers to answer questions about what is needed to keep implementing this type of intervention, a quality of life assessment intervention in clinical practice. Our methods involve, of course, recruitment of healthcare providers, patients, and family caregivers. I'm talking here about a series of studies, so I'm not going to give you the details of every individual study, just giving you a picture of how the different studies have been, or how they're typically developed. We do interviews and focus groups with clinicians and patients and family caregivers. We've had over 40 focus groups so far, and many interviews. We also ask patients and family caregivers, of course, they complete their quality of life assessment information as well as other information. We integrate that with electronic health records and then use that to do our outcomes evaluation. That's roughly how the research is structured. I'll share briefly with you the results of 3 studies that have been recently completed. The first study has to do with how we actually ended up designing and introducing this idea of a quality of life and practice support system. And the second study has to do with integrating it in clinical practice. And the third study focuses on the relational use of this type of a system, in this case in particular in hospital palliative consult care. So the first study has to do with the design and introduction of a quality of life and practice support system. And although the idea seems quite simple, it's actually not so straightforward. That's what we learned. This is predominantly qualitative work. You could read in this manuscript here, you could read about all the methods and so on, but there were many focus groups and interviews that I referred to earlier with clinicians and nurses, predominantly nurses, and patients and family caregivers. And roughly we learned about both the facilitators and barriers, enablers and challenges at healthcare organizational levels pertaining to the use of point of care and pertaining to the health technology context in which we're supposed to be we were integrating this type of quality of life assessment system. So in our interviews with clinicians, for instance, with respect to technology, clinicians were very concerned about very practical issues, logically so. They don't want to run into technical challenges. And so there were issues with portability, issues with connectivity, wireless. Some teams really still wanted the printing functionality. They're still kind of paper-based, although most teams are moving towards electronic systems, and some are already well established in electronic systems. There was also still quite a desire for printing. So those are the types of things we learned. In terms of portability, we now use that information to develop a system that can be accessed online via tablets, via iPhones, or other type of smartphones, and just generally via the web interface. And of course, we've worked to get all the privacy approvals for that in place. So that's a snapshot of the technology aspects. At the healthcare organizational level, we learned about needing to have a very good understanding about the organizational context in which these quality of life assessment systems are to be integrated. And so so we need to understand a pre-existing organizational context, the type of familiarity that teams have with quality of life assessments or the use of these type of tools, and how they have been introduced in the past, for instance, could really influence how they're going to be the take-up in the current environment. And so there is very much a need for some kind of environmental scan, understanding the organizational context in which these systems are to be integrated, and also understanding how the organization at the leadership level actually wants to use the information as well. Of course, the information, once shared by patients and family caregivers, becomes part of the hospital administrative health information systems and could be used for a variety of purposes. And clinical teams are, of course, quite concerned about this idea of it being used for surveillance type of purposes, which is perhaps not the original intent for which the information is being collected. It's being collected to support person-centered care planning. And so there was concern about that. And it's important then to be aware of those concerns and work with the healthcare organization to address those concerns. Then at point of care, we've had lots of interviews focusing on integration of point of care, and clinicians, and these are predominantly nurses and physicians as well as social workers, commented on some were quite unfamiliar with this notion of using standardized assessment tools and expressed some discomfort with that, and were also concerned about the burden that the use of these tools might raise for patients and family caregivers. There were concerns about how do we integrate this into workflow and how do we merge this with our existing clinical practice. There were also opportunities discussed, particularly focusing on identifying concerns that may otherwise not have been revealed or addressed. So here's an example, another video of a clinician who's been using these quality of life assessment tools in as a palliative consult nurse. And I'll just let you listen to the video without saying too much here. Hopefully it works.
So one of the patients that I used the QPSS with several times, he was quite a gregarious, like outgoing gentleman, and he was very keen to participate and talk with us. And he found the process, I think, very therapeutic and was articulate enough to be able to like tell us that, like he said, this has been really good for me to reflect on some of this stuff as well. And I think he really appreciated that we were able to raise some of these things and give him the opportunity to think about it. And as we met with him several times and went through it several times, and it really gave me a great benefit.
Yeah, so that gives you a little bit of a sense of the experience. So this is a nurse who started to use the system with her clients as a palliative consult in the context of a palliative consult team. So visiting people in hospital units, residential care, and at home, and so on. With this tablet, she specifically used it in a tablet format to go through these quality of life assessments. And initially, of course, there is a learning curve involved, but in the end, it became an extremely positive experience. And both the nurse and the patients receiving care started to learn about how the assessments could actually be very time efficient in directing care and discussion towards in a very efficient way towards the concerns and priorities of the patients, and to also engage into topics that would otherwise be missed or might not easily be engaged in. So, for instance, if you ask somebody about, for instance, the depression question, you can use that information. If a person raised that as an area of concern, you could use that information as an door opener to then talk about the area of mental health and so on. Just turning back to the presentation now. So the second study I'll briefly share with you about, and again, you could read about these studies in these articles, so I'm just giving you a brief snapshot here for the sake of time. But it is about the integration of a QPSS in a palliative care unit. And there we looked at that this assessment information, that it's important to be cognizant that this assessment information is used for different purposes at different levels of decision making. And so we use the micro, meso, macro type of framework, where we learned about how the information can be used at individual levels of decision making, focusing on care planning, continuity of care, integration to practice, which is most what we've been talking about so far, but also at meso level of decision making for quality improvements, identifying gaps in services, decisions about different types of treatments, cost effectiveness, and so on, as well as at macro level of decision making, at the societal level, focus on population health, decisions about cost equity, and healthcare policy. Now, all those different types of priorities, they play out in when these quality of life assessments are introduced within a healthcare team. And the manuscript that I just shared talks about some tensions that we need to be aware of and that could arise due to these different types of priorities of different stakeholders. One has to do with the tension between the benefits of mandated use and discretionary use of these type of assessment tools. And so, of course, with all of these, we're mostly looking at these tensions in terms of dialectics and trying to find out how could these tensions actually help move towards a positive outcome. But the first step is to be aware of that some people have a very strong reaction for or against the mandated use of these type of systems, and others have a strong reaction or stance towards the discretionary use of these types of systems. There's also stances, tensions surrounding the relationship between standardization and quantification with a focus on person-centeredness. And so some people see this as kind of being in tension, and others can very much see that standardization and quantification could actually help to support person-centered care. And so that tension is something we need to be aware of as well. And then third is about the scopes of practice. When we ask people all of these questions, who is supposed to be the one, or who are the people addressing all of these areas of concern? And is it everybody's concern? Is quality of life everybody's concern, every person in the healthcare team? Or are there particular areas of quality of life that different team members need to pay attention to? And how do we work that out when we negotiate and work out our scopes of practice within interdisciplinary and interprofessional teams? And then finally, the third study has to do with this idea of relational use of a QPSS. In this case, again, we're focusing on a palliative consult care context. The interesting piece of this study here, well, the aim was to understand the perspectives, the experiences and perspectives of patients and clinicians surrounding the features of a QPSS and its use in clinical practice. But the interesting piece that came out of this study was really this focus on relational use. Often we view standardization, quantification, and technology as something that's cold and impersonal. And yet, out of this study came quite a bit of information about, well, how actually these type of systems can be used to establish and to reinforce or further develop therapeutic relationships. And so you could read about that in this paper here, about how the assessment tools were used to increase visibility of quality of life within the hospital, quality of life concerns within the hospital setting, to facilitate relevant conversations about quality of life and experiences of care. How they were used to promote therapeutic relationship building, how they were used to co-produce new knowledge about quality of life assessment and care experiences that may otherwise not have been considered in that particular practice environment. And with the ultimate goal, of course, towards improving person-centered care. So here's Marion Krosik. She was a postdoctoral fellow with her team and is a medical anthropologist. And this is his last short video that I'll just share with you, where she is sharing here about her postdoctoral research, the study I just described. Oh, I need to click the play button. Bear with me here. There we go.
One of the aspects of the QPSS is that it enables different understandings for a patient of what they can communicate. And there was this instance I saw between a clinician and a gentleman who was in relatively young middle age and had had a diagnosis not too long previously, and so was still really trying to grapple with a changed identity, and he was in the hospital for a really rapid onset of symptoms, and he had a machismo to him, and his perspective when talking with the clinician was, everything is fine, I'm going to get out of here and I will start riding my motorcycle again next week. And it was a very unrealistic expectation, and the clinician wasn't really sure how to continue that conversation in a way that maybe would create a shift in understanding for him without it feeling like she was pressuring him to have an understanding he didn't yet have. And so when she was using the QPSS with him, some of the questions that were being asked were really about his understanding of his quality of life. And when he started answering questions about how he was feeling in the moment, he's opened up, and it became understood for him that he wasn't feeling well, and that he probably wasn't going to be feeling well again. And there was a third space that was created where he was able, through
the questions to answer in a different way about his emerging understanding that his identity was shifting, that I don't think would have been created elsewhere. And then at the end of that conversation, what was really interesting as well was that when the clinician left the room, she went and she charted this conversation to share with the other team members, because this was a really important shift in understanding around discharge planning. And so the results were significant and informed care, but also the very process itself was a care act.
Good. So that gives you a little bit of a sense of the research we've been doing, focusing in this case on the relational use of these types of systems in clinical practice. So I'm going to conclude this presentation. I realize I'm just giving some snapshots, hopefully whetting your appetite to read more about these studies and learn more about quality of life assessments. I'm going to conclude with just a few minutes drawing attention to the knowledge translation work we've been developing that is funded by the Canadian Frailty Network, where we're developing knowledge translation tools to help support quality of life assessments in clinical practice and at all levels of healthcare decision making. And there we're focusing on basically 4 user groups. We're focusing on the adults and family caregivers, the healthcare providers, the healthcare managers and leaders, and the government leaders and decision makers. As you may recall, a couple of slides back, these very much correlates with the micro, meso, macro levels of decision making and the different types of purposes for which we use these tools. So at the patient level, okay, so we've been developing, basically we have a website that we're developing and that where we're sharing all this information, including the videos and some other videos that we've been developing. Just moving on here. So what we're developing resources for older adults and family caregivers. We have a pamphlet that's coming out there, and so it's a bit of a stay tuned. So that, but if you're interested, you could email me. I'm happy to share the current resources with you. All this is becoming available by the end of this year, including some videos. This is the video that you saw a snapshot of earlier. Similarly, we have resources for healthcare providers. How do we even start a quality of life conversation, quality of life assessments conversation? And what are some of the myths and truths about quality of life assessments? So it's kind of our Mythbusters page. Similar for healthcare leaders. Healthcare leaders, again, managers and leaders have to have a resource about starting the conversations about quality of life assessments, but also making a difference. How do we actually use this data for quality improvement and other types of decisions? And then at the policy level, through our interviews and so on, we learned how people in policy and government benefit a lot from brief fact sheets and some frequently answered questions that they can then use to develop their memos and communication strategies when they talk to others about the importance of this information. Overall, we've learned that when integrating quality of life assessments into clinical practice, there is very much a need for continuing competence, education, and knowledge translation. Roughly, the areas of competence have to do with, for clinicians, have to do with how do we actually introduce this notion of quality of life assessments in our daily practice? How do we review and use that quality of life assessment data with patients and family caregivers? And how do we engage then in an intervention based on that quality of life assessment data, while obviously combining it with our other clinical assessments and clinical judgments? One area that we've been looking at is how do we then integrate these competencies into our basic education? and our colleague here, Tracy Stevens, and Andrea Orr and Landa Treblanchen, and I have recently done a kind of a pilot, a test case of developing assignments around quality of life assessments and integrating that into our curriculum. So you could read about that in that publication over here. So I realized that was a very high-level overview of a fairly substantive program of research, but I hope it gave you a good sense and introduction and interest to engage the topic of quality of life assessments some more. Please feel free to email me. I'm very happy to collaborate and answer questions and share any of the resource. Everything's open access, of course. And I'll leave it open now for any questions. We've got 9 minutes remaining, so thank you.
Daily challenges.
Thank you very much, Dr. Sawatsky. So as you mentioned, it's open for questions. So anybody would like to, or anybody has a question? I think we have to, in the meantime, we have to commend the clarity of your presentation and how you synthesize a huge amount of research and of information very clearly. So someone is typing.
Oh, thank you.
Is typing a question, so we'll have it very soon.
Wonderful.
So there's one more coming. So don't forget to push the click button so that we could see your question. Okay, Linda Glass is asking, how extensively are QPSS tools used in palliative care in the US and Canada?
Yeah, that's an excellent question. I think we're at the cusp of seeing some change. There is a lot of motivation to integrate these tools. The notion of quality of life assessment has in part arisen out of palliative care. And you know, in the UK, there has been quite a bit of development with the palliative outcome scales and the teams over there, and also the use of electronic systems integrating into practice. In Canada and the US, I think we predominantly see most of the development in cancer care. So there's electronic systems and routine use of these tools in cancer care. We've seen it in Ontario, for instance, where the Edmonton Symptom Assessment Scale is used routinely in clinical practice. And we see it in some niche pockets of throughout the country. For instance, we see a lot of attention in kidney care and dialysis care, people with kidney disease. And of course, these are all life-limiting illnesses. And so, well, they're not perhaps strictly palliative, but they are life-limiting illnesses like early palliative care. And that's really where I see a lot of the potential happening for these type of tools. The US, I'm a little bit less familiar with how much they're being used, other than that, yeah, the cancer care environment for sure.
Thank you very much. We're still waiting for the second questions because people are typing. And Linda Glatz is saying, thank you for the answer. Nicola Thomas is saying, excellent presentation, thank you. Can you speak to the update of the tool within your study by clinical providers? I have used QOL tools for asthma management. It is very difficult to have practitioners integrate them.
Yeah, exactly. And that's been our finding as well. That's really describes the challenge that we're trying to address with the research. We've got a lot of evidence basically that the tools could be quite beneficial. We've also have a lot of evidence that there's a lot of misunderstanding of the tools, that people think that they're difficult, that they're, for instance, going to be time consuming and so on, whereas that need not be the case, as long as it's well integrated. So in our studies, every integration initiative, we've really use this type of integrated knowledge translation approach where we start with the teams. We have found that the top-down approach doesn't really work as well, where clinicians are basically told you use this tool and figure it out, and provided some educational resources to support them. We think that a bottom-up approach is much more effective, where we meet with clinical groups, try to figure out what their knowledge gaps are, what are their gaps in skills, in attitudes, in knowledge surrounding the use of the tools, and then developing a knowledge translation plan to help address that. So that's actually really where the work is. Once that has occurred, we find that it's actually quite successful. So once the clinical team start to realize that, completing these tools actually takes only a few minutes, and actually within that time I could much more quickly identify what are actually the priority areas of concerns. And by the way, I could also use this to track over time how people are doing with respect to their symptoms and their emotional well-being, their social well-being, and so on. And at the same time, we could use that for quality improvement purposes. Once that idea starts to take shape into clinical teams, and then it becomes normalized in practice. But we still have quite a long way to go for that to happen.
Yeah, and I think you provided, in one of the short videos, you provided an example of how a nurse was using it, and it was beneficial for the relationship between the patient and herself. So Nicola is saying thank you.
Thank you, Nicola. Yeah.
I think Megan is typing, but the question that Megan is raising is, does the provincial government use QOL measures for health services reports, for example, review of LTC services?
Yes, that's a great question, and I'll keep it very brief, but I'm happy to have more correspondence about that. The Canadian Institute for Health Information actually increasingly is kind of a driver or an organization that's facilitating the use of this type of information at more organizational and health policy levels of decision making. So if you go to their website, you'll find out about the use of these tools in long-term care settings, for instance, but also in other sector-based type of surveys, be it community-based type of surveys and hospital care. Now, the drive is, of course, to make it a routine use of these tools in clinical practice, so that we're not just collecting this information through surveys, but actually have real responsiveness and real-time information about how we're doing. So I think that's all I can say within the brief time we have right now, but happy to share more.
Thank you very much. So thank you again, Dr. Sawatsky. Our time is almost up. And thank you, everyone, for your participation today. Just to remind you that the session had been recorded, and it is going to be available for the next month on the CASN YouTube channel. Thank you again. And CASN certainly hopes that you will consider attending future session this fall, winter, or spring of our Lunch and Learn series, and visit the CASN website for more information. So thank you again, Dr. Sawatsky. That was very interesting, and there is a lot of people writing thank you on our screens.
Wonderful. Thank you, everyone.
Bye-bye.